Thank you for all being here today. This is another portion of our HealthCARES educational series. I'm Lindsay Covington. I'm the Director of Communications and Community Engagement here at HCA Florida Lake City Hospital, and we have definitely a full room today, so I appreciate all of you coming here and showing up and being interested in our topic. And then we have our Facebook Live that's going on, so hello to all of our viewers today. We appreciate you logging on and being interested in learning more about our topic today. So I'm going to turn it over to Dr. Vasquez. She's a general surgeon here at HCA Florida Lake City Hospital, and she's going to go into her presentation and talk more about her topic for today.
All right, thank you, Lindsay. All right, hello everyone, and for the patients or people in the Facebook Live, thank you for joining. We do have other healthcare series online already, so make sure to check on those. We did a couple for gallbladders, hernias, and also colonoscopy. So we'll go over today's talk will be on colorectal surgery, but we will just give a brief presentation on people that still don't know me or are logging in for the first time in Facebook. So I'm Dr. Vasquez. I'm an HCA Florida Lake City surgical specialist. I'm a general surgeon. This is where I practice. This is where we are right now. We have several general surgeons in the hospital, and I am one of the employees for the HCA. This is my staff. This is our office in Lake City. We're just across the Highway 90, so we'll have the information about the office at the end of the presentation. And the gentleman in the picture is Dr. Wong. He is also an HCA general surgeon that has joined our practice. We do a lot of surgeries in the hospital. We have reached almost 1,000. We've reached 1,000 and more robotic cases. We do minimally invasive robotic surgeries as well as open surgeries and emergencies. That's some fun pictures. And then a little bit about the hospital. I always want to kind of do a brief presentation of it because we're really proud of it. It has been growing a lot in the last several years. We are about 113 plus beds. The ER has brand new beds from last year as well. We have now opening, we have 3 OR rooms, but we have a new tower that's opening soon. We have state-of-the-art robotic technology as well as cardiovascular services. This is a little bit of an explanation of how much we have been expanding in the future. For the future, and then this year, we would be opening our new OR tower, which will have more space to continue to service our community. So a little bit about the practice before we go into deep for the colorectal surgery or the colorectal cancer surgery presentation. What other surgeries do we offer? So skin lumps and bumps, lipoma, cyst, skin cancer, pilonidal cyst, also lymph node biopsies. We get a lot of referrals for that. Something very common that you'll see in different populations as well. These are most likely benign lesions, but we can definitely take care of them. Emergency surgeries like for gallbladder, appendix, gastric perforation, colon perforation as well. We would all take care of them here. We do robotic surgeries for gallstones, hernias, sometimes colon as well. So now we are getting also our second robot, which we're all so excited about getting to continue to grow the practice. And last but not least, we also offer surgeries for diverticulitis. We do EGDs, colonoscopies, and for colon cancer resection. This slide is important because we are going to jump into what we came in here for to learn a little bit about the colon cancer. This is, in March is the Colon Cancer Awareness Month. Very important to just briefly go over the pathology, the risk, what are the benefits of colonoscopy, and what are the different types of treatments if you do get a colonoscopy and you're told that you have an abnormality or something in your colonoscopy. So why is it so important? So everybody talks about of course, the cancer word, nobody wants to hear it, but it is important to know that colon cancer is not the end of the world, but it is very, very common. It is the third most common site for new cancer in both women and men in the United States. And it is the second leading cause of death from cancer. And the first one being, that's shouldn't be it should be lung. That's a typo. But lung cancer, because unfortunately here in the United States, there's a lot of smoking. So lung cancer is the first one that you would die of cancer. After that is colon cancer, which is very, very sad because you can prevent colon cancer, and we'll show you how. And it is the most lethal GI malignancy in the Western world, and it's mostly from the diet. Here, more than 90% of new cases of invasive colorectal cancers are diagnosed in patients 50 or older. If you're 20 years old, the chances of you getting diagnosed with colon cancer is not high unless you have some risk factors, familial syndromes and stuff like that we can go over later. But after 50, you have, like more than 90% of the cases that are diagnosed are going to be after 50 years old. And the 5-year survival. So here, this is actually pretty important. We can see how the trend of survival rates go high, like keeps going up the longer we kind of continue studying this type of malignancy and provide the services for it. So it's not like we're getting worse every year. The cancer risk or the cancer screenings are getting better. So we can see that there's a little bit more colon cancer detected, but it doesn't mean that we are dying more of colon cancer. We're actually, doing pretty good. You can survive. And the most important part of this presentation is this slide. If you're going to take anything from today, just take this. Like, it is a preventable and highly curable cancer if it is detected early. Lung cancer, that's completely different. So, like I was saying, it is rare prior to age of 40, but after 50, that 50-year mark, the risk of getting it increases significantly. So at presentation, have we seen in like the prior, studies and stuff like that, 37% of these malignancies are only localized in the colon. So if you get diagnosed with colon cancer, you have a 37% of just having colon cancer localized in the colon. Unfortunately, 20% of the time, you already have a metastasis, like a lesion in your lung, a lesion in your liver, or a lesion somewhere else other than in the colon. 75% are sporadic, which means that you just got it. You just got the colon cancer from a polyp, that it's not coming from your family. You don't have a diagnosis of any rare disease that increases your risk of colon cancer. It's just sporadically happened. We'll see the risk factors later, but it's mainly due to the diet and to the habits. And then the rest of the 25% of these cases are secondary to the genes. So who are these patients or people that are at high risk? Like, are you at high risk? ? So the hereditary polyposis syndrome are these syndromes that at age 20, you have thousands and thousands and thousands of polyps. These are rare diseases. They're genetically, they're genetically transferred from families to families. So you would know if you are one of these, patients or one of these people, because your dad is going to, have the gene, so it'll pass it on to you. Lynch syndrome is another syndrome that is associated with colon cancer. You would definitely know because Lynch syndrome is also associated with different kind of cancers in your body. And they do have an 85% lifetime risk of having colon cancer. Inflammatory bowel disease like Crohn's or ulcerative colitis. These two diseases, Crohn's and UC, increases your risk of having colon cancer significantly. Therefore, your risk is not the same as a person that doesn't have UC or Crohn's. So therefore, you should talk to your GI doctor or to your surgeon about getting the appropriate screening for that, diagnosis. And also having previous colon cancer will also increase your chances of having a cancer in the future. Unfortunately, colon cancer, yes, it is preventable and it is easily treatable, but once you get it, the chances of getting it again, it increases. So also very high risk are the first degree relatives. This is something that Unfortunately, I've seen patients that, oh yes, my sister had colon cancer at age 50, but I don't want a colonoscopy. I'm just scared of the anesthesia. You have almost an 8-fold increase risk of having a colon cancer if your first degree relative has it, including mom, dad, or siblings. Those are your first degree relatives. It is higher if one or more are affected. If your dad had colon cancer and your sister had colon cancer, the chances of you getting colon cancer is significantly higher as well. Or the younger you get the diagnosis of colon cancer, well, the more risky you will have. So if your sister or your parents had it at age 20, you definitely need a colonoscopy. So what are these risk factors? So these risk factors have kind of changed a lot in the last several years. Like there's been so much studies and a lot of data that yes, red meat increases, no, red meat doesn't increase. It depends what red meat, if it's deer meat, cow meat, whatever meat. Red meat increases your chances of having colon cancer. Why? Because of the density of it. So the fatness or the cholesterol in the meat, or the cholesterol like in the food that you eat, will increase the cholesterol levels on your stool. That will increase the abnormalities on the mucosa that you will get in your colon. So your colon is basically like the trash bag, right? Like whatever you eat, the body will take whatever it needs nutrition-wise. After that, it just goes into your colon and you just have to wait until you dump it in the toilet. So if you think about that, the more heavier stuff that you consume that stays in your body longer, like red meat, the more transit time in your colon, the more it stays and lingers there in the colon. The longer it lingers there, the more chances of doing something bad to your mucosa. So anything that will increase your chances of having a bowel movement, like a lot of people will say Metamucil, drink a lot of Metamucil. Colorectal surgeons will die with Metamucil. That's their best friend because it's basically fiber. It increases your bowel movements a day, or it makes you go on a normal habit. Metamucil is great. The more you empty your trash bag, the worse, the better it's going to be. So you won't have flies or you won't have anything in your kitchen, right? So you don't need the trash there. If you're a constipated person, start getting Metamucil, fiber a day, a lot of water. So you can flush all that cholesterol in your stool to decrease your chances. Also, alcohol consumption. I think that this alcohol is in every risk factor list in the history of the healthcare. Like, just alcohol is just not going to be beneficial for anything. So it is also known to be linked to colon cancer. Folate is known to be protective. A lot of, in pregnancy, you take a lot of folate for, pregnancy stuff, but it has been linked to being protective against colon cancer, as well as aspirin and NSAIDs like Advil, or which one's the other NSAID? Toradol, stuff like that. Again, this is not like I'm telling you if you take Advil every day, you won't have colon cancer. Well, no. It has been linked that Advil or aspirin or any NSAID will sometimes regress polyps, won't save you from cancer. You can't just say, okay, I'm going to take aspirin because Dr. Vasquez said, I'll take aspirin and I'll skip my colonoscopies. No, but it has been linked. And also calcium supplementations decreases the risk of having new adenomas. So where does this cancer come from? Because I did say already that 75% are sporadic. So where do they come from? So cancer, most of them, like almost 90% of the time, it comes from the polyps. So you can have bad polyps, like the neoplastic polyps, or non-neoplastic polyps, like the colonoscopist will say, yeah, we found 3 polyps, they were hyperplastic polyps, or they're like, normal polyps or whatever polyps, nobody cares. If you did get an adenomatous polyp or a neoplastic polyp, those are the polyps that if you wouldn't have seen or you didn't get removed, those are the ones that are going to continue growing and growing and growing to a colon cancer. That's why it is so important to take all these polyps out. So where are these, or how do we find these? So these adenomatous polyps, the bad polyps, after 50 years old, 33% of your polyps are going to be bad polyps. That's why at the beginning, we said once you're 50, you definitely need to get a colonoscopy, because one of the 3 polyps that you're going to get is going to be bad. And if we leave it there, it's going to lead to colon cancer. If you never had a colonoscopy and you're 70, 50% of those polyps are probably malignant polyps. That's the importance of it. And then if you leave it untreated and you're like, no, I'm good, I don't have any symptoms, I go to the bathroom every day, I've never seen blood in my stool, you know, I work and whatever, I don't have time for it, 20% of the time, these polyps will lead to cancer if we don't treat them. So, which leads to, did you get your colonoscopy yet? You know, like, how old are you? We changed the screening recommendations because of the terrible diet that we eat. 50 is not enough anymore. 50 is no good. We have dropped the recommendations down to 45 years old because we have seen more and more and more colon cancer on younger people every year. Unfortunately, we see colon cancer on 30s, you know, age 30, and that wasn't normal in the past. That was like completely rare. Now it's like, yeah, this guy also got unlucky. But again, this is the normal patient that smokes and drinks and is morbidly obese, you know, and that's unfortunately, all of those risk factors are there. So with a colonoscopy, why do we, you know, brag about it so much? Because we can actually see the polyp. If we see the polyp, we can endoscopically remove the polyp. Right then and there, we just put like a lasso over it and just yank it out. If it cannot be completely removed, it's okay. We can biopsy the polyp too. Sometimes it's like a normal polyp. It's nothing malignant. We can just biopsy the polyp, take it piecemeal, and then just remove it. What if the polyp is so big that we can't get it removed? So if we can't remove it, unfortunately, we got it to grow a little bit too big, then we would have to surgically remove it. So I'll show you different techniques to remove that polyp. This is kind of like how a colonoscopy goes. If you haven't had one or you haven't seen how it is basically a camera. I've said this in prior presentations. It's a camera up your butthole. It's nothing bad. You won't feel it. You're going to be asleep, you know, and the procedure has its risks, but the risk of having colon cancer in the future definitely outweighs the risk of having a complication during this procedure. We definitely take a lot of caution to it. So before this day, your surgeon or your GI doctor will tell you your colon needs to be squeaky clean. Why? Because we're going to put a camera on your colon. If there is a lot of stool in there, we'll be, you know, playing tag it because we won't be able to see anything with the stool ball. So I think the worst part would be getting your bowels prepped. So taking really, really good care of getting your colonoscopy bowel prep, taking all the medicines, and making your colon squeaky clean. Like the day of your colonoscopy or the day before the colonoscopy, you should be basically pooping yellow water. Once that happens, you get to your endoscopy suite. They'll give you some propofol or like medicines to put you to sleep, and then we'll go up the entire way through your rectum, up your left side, move to the right side until we find either the aperture of the small intestine right there, or we can also see the aperture of your appendix. And then we can say, we saw your entire colon, looks good, there's no polyps. If you're that person that you didn't have any polyps, your bowel prep was good, we were able to see everything good, then you don't have to repeat it for like 7 to 10 years. If you're found to have several polyps, then we would go and do your recommendations. Like if you had 2 non-malignant polyps, then we could say, yeah, it's like there were only 1 or 2, come back in 7 years. If we found more than 1 polyp and 2 of them were like, ooh, if we would have left these, they could have been cancer, we could, you know, you will probably say come back in 5 years. So depending on what we find or the number of polyps or the characteristic of the polyp, then we'll change your screening rate to 5 years, 7 years, you know, 10 years, or even 3 years. These are kind of like how polyps look. This is what we call like a snare. Like out of this instrument comes like a little lasso kind of thing, and we just like go around it. So if we don't take it out, like this polyp was easy peasy, we could take it out, we burn a little bit, and then this polyp, we suck it out, send it to pathology, and they'll tell us what it is. If we either don't get a colonoscopy and we just leave it to grow, you can have you can have tumors already, because that polyp continues to grow and grow and grow. The polyp probably was this small, and it just kept growing until it was a partially obstructing mass. So once it's like this, just imagine, like, we wouldn't be able to take care of it endoscopically. So at this time, we either take a biopsy to see what it is and then plan for surgery. Sometimes we can do some tricks to get more, like, bigger polyps removed. So if you have, symptoms, right, of colonic polyps or colon cancer, what are your symptoms going to be, or what should you be, taking into account? Is like blood in the stool it can be from many, many things. It can be from hemorrhoids. It can be from, like you're taking, you see your stool is black, but you're taking iron supplements. So not every time that you have blood in the stool means colon cancer. But when you have colon cancer, the chances of having blood in your stool is high. So if you all of a sudden go to the hospital or to your doctor and you're like, I'm having a little bit of abdominal discomfort. I used to go to the bathroom normal. Now my stools are super thin, like kind of pencil-like stools. And sometimes I see blood on it, and I've lost 20 pounds and I'm not on Ozempic, then you probably need to see, a surgeon or or get a colonoscopy, because that is not normal. So if you think about this polyp and the stool is trying to go around it, you're going to have thin and pencil-like stools, because the stool is supposed to be the size of your colon, basically. And then constant fatigue, because if you're bleeding out, right, or you're slowly bleeding from that tumor or from that cancer, your blood levels are going to go down. So you're going to get what's called anemia, right? And that will give you fatigue. Plus, you're growing a cancer. Nobody feels great when they have cancer. What are other manifestations? Well, the symptoms depends on where your colon cancer is. So if I go back to this picture, the farther on your left side, right, because your left colon is the colon that's going to be ready to empty into the toilet. So that's going to be the stool that is the most solid. If your tumor malignancy is on the left side, then you're going to see a lot of changes in your stool. If your tumor was on the other side, close to the appendix, that stool is usually liquid. You won't have a lot of constipation or anything, because it's just liquid stool. But the further it goes to your left side, ready to go into the toilet, the more solid your stool gets, the more symptoms you're going to get. So the symptoms depend on where in the location of the colon is this tumor. So this is exactly what I was saying. If it's proximal on the right side, you won't get a lot of symptoms. So you might not even have symptoms other than fatigue, right? But no changes in your stool, no changes in the color, no changes in your bowel habits, basically. But if you start having ulcerations and blood loss, then you will have fatigue. And you'll say, yeah, sometimes I get palpitations, or I can't go up the stairs anymore because I get super fatigued or super tired. Then sometimes people get even chest pains because there's not enough blood now circulating your body to supply blood to your heart. So if you go to your PCP might order CBC, or like basic labs, which will show anemia, like your blood levels are lower. Or they will just quickly do an FOBT, which is a fecal occult blood test. They will ask you for a piece of your, let me say this politely, of your stool, and they will test your stool and see if it has blood on it. If it has blood on it, next step is colonoscopy. So if your cancer is here, you're going to have pencil-like stools. If your cancer is here, your stool is basically just coming out from your small intestine, it's like going to bypass it. You're not going to have any constipation symptoms. So not always you'll have the same symptoms. The cancers at the end on the distal are mainly the ones that are going to kind of constrict, which will then cause cramping, a lot of cramping, obstruction, or even perforation. So how are we going to diagnose it? So you go into your PCP and you tell them your history and your physical exam. You're like, yeah, I've been doing okay, but 5 months ago I started feeling like some abdominal cramps. Now I can't work in my yard anymore. I get really tired really easily. And yeah, talking about my family, my dad had colon cancer when he was 50. And I also have ulcerative colitis. Those are things in the history and physical that are kind of very, very concerning for malignancy as well. They'll order the FOBT or the fecal occult blood test and a CBC. So if the fecal occult blood is positive, that there's blood, then you're going to go into your colonoscopy, which is the choice for all patients. So what are the current recommendations right now? At 45 years old, if you're average risk, if you do not have any of the rare syndromes that I mentioned, if you do not have a family member with colon cancer, if you do not have ulcerative colitis, and if you do not have Crohn's disease, that's like an average risk. You can start at 45. You should start at 45. Depending on what it shows, then they'll tell you how often you have to get in. Or if you don't want to do a colonoscopy and you're asymptomatic, the asymptomatic part is really important, because if you are 45, but yes, you do have blood in your stool and you're always constipated and you have abdominal pain, then you have to get a colonoscopy sooner. Or if you're 35, right? So this is like the normal 45, easy peasy, walkie-talkie, no symptoms. If you don't want to get a colonoscopy every 10 years or 5 years, then you can get the blood in the stool test every year. It needs to be every year. Your PCP needs to order it on a yearly basis. If this FOBT is positive, then you have to get a colonoscopy. There's another thing called the FIT, which is fecal immunochemical test. Is also, they'll take a sample of your stool and they'll test it. If it is positive, it follows a colonoscopy. And then if the colonoscopy is negative, then you do it every 10 years. Or you can do a sigmoidoscopy. We've seen that most of the malignancies are on that left side, at the end. Because again, if you think about it, that's where the stool gets clumped up. That's where the stool is hard, puts pressure on the walls. Kind of like that's where you get the diverticulosis. All the problems mainly are at the end of the colon. So if you do get a sigmoidoscopy, which is just a colonoscopy, but not all the way to the other side, it's just on this left side, you have to get it every 5 years. If this colonoscopy or this sigmoidoscopy is positive, then you have to get a full colonoscopy. Or this virtual colonoscopy, it's a different colonoscopy. Basically, you will still have to do your bowel prep, and you go to this endoscopy suite, and they will put a rectal tube with a balloon, and they'll push like a lot of CO2 air, and then they do a CT scan. It kind of like takes really, really good pictures of your colon, but it's not a real visualized colonoscopy. And guess what? If it shows a malignancy or shows something irregular, you're still going to have to do a colonoscopy, because it's not something to treat, it's to diagnose only. And then, so if you are a normal person with good health, that you're expected to live more than 10 years, you continue recommendations to 75. Again, if you're 65 and you're on hospice because you have, I don't know, pancreatic cancer, then the chances are you don't need a colonoscopy, because the pancreatic cancer is going to kill you before a colonic polyp. But if you're a good health, then you need to continue, because again, after 70, 50% of those polyps are malignant. So if you think that you're going to make it to 85, you don't want to make it to 85 with colon cancer. And then this, after 75, there's a range that really the decision to keep going with a colonoscopy depends on, patient's preference. Oh yeah, I don't want to do it anymore. I moved to the villages. I'm retired. I just want to party and not get a colonoscopy. Then fine. Then whatever. Just don't get it. But if you are, if you're now 80 and you're getting now more grandkids and you're a very active person and you want to keep getting screened, then yes, because you think that you're going to be able to make it to 90, then get screened. More than 85, you're done with screening. Like the chances of you getting killed with cancer is like you're going to be 95. You have to die of something, I guess. So you got your colonoscopy. What now? Like, what do? Like your GI doctor saw you in PACU or in your post-anesthesia care unit, and it's like, oh yeah, there was several polyps that we removed. Okay, so oh my God, I got several polyps removed. So you follow up with him. Oh yeah, or with her. They were normal polyps, nothing to worry about. Great. Well, no, now different. You have a malignant polyp and we have to stage you. This word staging means, let's see how, how bad is this polyp? We biopsied its cancer. Well, the staging is to see what kind, or like, where are you in that word of cancer? Where are you right now? Is it moved to your chest? Has it moved to your liver? Like now you're diagnosed with cancer. What do you do now? They're going to order some imaging, right? The CT, chest, abdomen, and pelvis, to see if this cancer in your colon has moved elsewhere. If it hasn't moved, then you celebrate. If it has moved, it's not the end of the world, because now we have, chemotherapy and all those stuff. They're going to also order this lab called CEA. It's a tumor marker. It's used to see how bad your cancer was at the beginning, and then they'll test it in 3 months, 6 months, a year, and if the number keeps going down, great. If all of a sudden in 1 year they do another CEA and the number is high, then it alerts everybody to look for something, because the cancer probably is back. And then we will also refer you to a hematology oncologist. These are the cancer doctors, the medical doctors. They will most likely order a PET scan, and they will talk to you about chemotherapy. If it's in the rectum, we do radiation. How long the chemotherapy is, if you need it or not. What are the side effects of chemo? Do I need a port? Don't need a port? Like, all these things are going to be with the hematology oncologist after you get the cancer diagnosis. So if the polyp was able to be resected, then we just go ahead and resect it, even if it's malignant. Once the polyp is resected, depends on how deep it was in the mucosa, you just cured, right? You got the polyp, we got it out, you're done. If it's too big, we would be able to talk about advanced mucosal resection, which is advanced GI, like a gastroenterologist that does advanced procedures, that they would resect that polyp with the colonoscopy. If it is too big of a polyp, like the picture that we saw, then you have no other choice. You just have to remove that portion of colon. We do that open sometimes, like a midline incision, when you have certain other, comorbidities, like you've had many surgeries in the past and your abdomen is completely full of scar tissue that we cannot do it minimally invasive because of there's no space, or certain other things that as surgeons we do, like risk and benefits, to see how you're going to do better with either open or minimally invasive surgery. So this is the EMR, like the endoscopic mucosal resections that we say. If the polyp, you can have 2 different polyps, like a kind of like a polyp on a stalk, which is really easy because you just lasso the stalk. Sometimes the polyps are not that easy to take, and they're kind of just smothered in the mucosa. It's just really hard to really lasso that mucosa because there's nothing to grab. So then with EMR, they will kind of inject some fluid to lift this polyp and then take it. You can have that done. not by me. You will need somebody that actually knows how to do it, which is an advanced endoscopist. This is other examples of how you can get that sessile polyp basically just in like flat and make it a little bit elevated so you can remove it. And this is how it looks in real life. So you can see how kind of like hard it was to get that lesion on the top picture on the left. So once they inject it, they elevate it and then they remove it. Or if they can't remove it like that, then you would have to get a colonic resection. Colon cancer resection is different than just getting resection for diverticulitis or something like that. Because colon cancer resection, it needs to be a little bit more involved. Because I would never do colon cancers like a colon resection and then just take out a piece this small, because the chances of me leaving several cells in there are high. So the recommendations are that if your malignancy is here, you need to get 5 centimeters proximal and 5 centimeters distal. So you can't just like go in there, open the colon, carve it out, close the colon, because you would grow another colon cancer there. So you have to really take, for better prognosis and better, basically better results and prognosis in the future, you have to really just take a piece of it. The good thing is that you have plenty of colon. The bad thing is that depending on where the cancer is, it depends on what kind of surgery you need. So if you think about it, if it's a right colon mass, that we have to unfortunately take most of the right colon, because also it comes to what blood vessel is feeding this portion of the colon. There's these things called lymph nodes that live right next to the colon too. We need to take those lymph nodes so we can give it to the pathologist and say, this is your colon specimen, here you go, right? And then we leave some lymph nodes, some tissue there, so the pathologist can look at it and say, well, the lymph nodes are all clean. Okay, well then this cancer surgery was curative. Or they say, well, the lymph nodes had cancer cells on it. That's when the hematology oncologist decides you need chemotherapy or not. Depends on the lymph nodes. Because if the colon cancer moved to the lymph nodes, then technically it means that there's cells around your body with cancer. So not always you'll need chemotherapy. They'll be like, yes, we removed that portion of the colon. We removed at least 15 lymph nodes. All of them are negative. You're cured. If one of them was positive or 2 or 3, the chances of needing chemotherapy are high because we need to kill the cells that are swimming in your body. If you get your colon resected on that side, it's very, very, very far away from the rectum into like the toilet here. So the chances are, I think the most feared is, am I going to get a stool bag, right? Like, am I going to get a poop bag, a colostomy? So rule of thumb, not always, but very likely, if your colon cancer is on the right side, there's no stool bag that needs to be done. Because the small intestine, we can move it anywhere. So if we have to remove this colon, we just cut here and then move this small intestine to that yellow part and connect it. And that's it. And we just have to, this is literally, it's like plumbing. You take a piece out and then you hook it back up. But just imagine if we have to take this part. We have to connect it A to B. Sometimes we can't. And then that's when you get your stool bag. Is it like, do you always get it? No. You don't always have to get a colostomy bag. Again, it depends on where it goes. And sometimes you have a floppy colon or redundant colon. Sometimes you'll get a colonoscopy and they're like, oh my God, yes, it was so hard because you had a redundant colon. That means that you have a lot of colon and it's stretchy, and then we can cut and pull and put it back together. So you don't always get a colostomy or a stool bag after colon resection. It depends, again, where the cancer is located. But if you do get one, everybody's just like, oh my God, the end of my life. I don't know how I'm going to live with this. It is shocking. Yes. It is like, you have to change a little bit your habits, but you can live with it. You can live a normal life with it. You can even go to the beach, or go to the pool. You can. It just depends on how you think about it. It is going to be challenging to kind of like in a matter of hours, you wake up from surgery and you have this colostomy and the colon is literally just like poking out of your skin. It's scary, but it is very manageable and you can live a normal life with it. Do you have to keep it forever? You don't have to keep it forever. Most of the time you don't. If you do have a colon cancer down here, the chances of you having to keep it forever is high, because the lower it is, the more in the pelvis, like you have to go to like hook this. So for example, if you take all this out and you bring this as a colostomy, to reverse it, we have to bring this back down and go here. Sometimes the colon or the rectum that is spared there gets contracted because it's not being used. And it's really, really hard to kind of like put it back. Really good surgeons can do it. Those are the colorectals. So we can, yes, definitely do colostomy reversals where we bring wherever the colostomy was, right? You so now the colon is not like in that acute angle because we have to kind of like move it a little bit lower. So the colostomy was here and we basically bring it down, clean that top portion of it so we can make it nice and raw and new. And then we just basically connect it back to your rectum. So a lot of people prefer not to have surgery to avoid a colostomy. That's like the worst error you can do. If you need a colostomy, well, unfortunately, you have to get it for at least 6 months. That's the other timing kind of question. Like, how long do I need it for? Most likely 6 months. That's the minimum, because we won't be able to go into the belly again if you just had surgery. If you want to know a little bit more about colonoscopy, you can visit this healthcare series that Dr. Wong did. He goes into depth with it about colonoscopy, the risk factors, and how it's done, and a little bit more information about what I did. If you have had your colonoscopy and you're up to date, but you have a hernia, then make sure to look at this one. And that's it. Of course, I'm dedicated to you guys, to serving this community and supporting all the needs that you guys need in any way I can. And if you haven't had a colonoscopy, make sure to book your appointment. If you have a gallbladder, hernia, whatever you need, I'm here. Thank you for listening. I hope that this kind of answered several questions about the fear of colonoscopy, about the fear of colon cancer. I don't want to get a colonoscopy because I'm scared that they're going to find something and I'm going to get a stool bag. It's not the end of the world. It is worse when you don't get it and then they do your colonoscopy and it's too late. So, yes.
So thank you so much for presenting for us today. We have a Facebook Live question, if you'd like to answer that. And it's from Caitlin Morgan. And she says, what's a typical poly size that's seen during a colonoscopy? Does the polyp size indicate whether the patient has symptoms?
Very, very good question, because you can have so you guys remember that I said you can have a sessile polyp, right? The polyp that is basically just kind of like sitting there in the mucosa. These polyps can range in size from 1 to 3 centimeters, even bigger. But because they're kind of like a carpet right there, you won't have real symptoms of obstruction or anything like that. If you have what we call a pedunculated polyp that is like in a stalk, like it looks like a balloon in a stalk, then those polyps will, with every bowel movement, they'll kind of just like move like waves. Those will give you colicky pains too, and cause obstruction, constipation, gassy kind of feeling. Usually the polyps that will give you symptoms are polyps larger than 1 centimeter, because the colon, when it's empty, it's basically like almost kind of like 3 or 4 centimeters. It's not that big, really. If your colon is full of poop, then that's another thing. You know, you can have really, really decently big, you know, colon. But it depends on like, how is it? Is it like flat, or is it like coming out, like invading your mucosal kind of, I guess, like invading your space. So the polyps, again, like for her answer, you won't always have bleeding. You won't always have symptoms. The reason why we recommend the colonoscopy, because we just never know, you know. And the best answer, just only God knows. So, and yes, ma'am. Mm-hmm. So diverticulitis is not a malignancy, right? Diverticulitis is when you get like an outpouching, like a hernia, basically in your colon. So again, if you think about it, your diverticulitis or diverticulums is mainly going to be on this side of the colon, because this is where you get the stool balls ready to come out through your butthole. So you're going to get the more pressure in the abdominal walls, right? Here, it's just liquid. So not a lot of pressure in this wall. So this wall stays intact. When it becomes dehydrated and ready to come out, the stool gets bigger, pops these hernias, and then you get like these outpouching called diverticulums. As soon as you get an inflammation or an infection in that diverticulum, that's called diverticulitis. As soon as you get that diagnosis, you have to get a colonoscopy 6 to 8 weeks after you get diagnosed with that. Because we need to make sure that your inflammation is from actually a diverticulum rather than a malignancy. Once they diagnose you, yes, it was only diverticulitis, then you go back to your normal screening. We don't screen for diverticulitis, only the first time. Like you came to the hospital, they treated you with antibiotics, and then they said you have to get a colonoscopy in 8 weeks because we need to make sure that that pop or that inflammation was only that, and it's not a new polyp trying to become cancer that kind of popped or something. Any other questions? No. Okay, good deal. All right, thank you very much for people that are in Facebook. We're done.